All right, good afternoon or good morning, depending where you are. I hope you're all doing well. Thank you so much for joining us today for this ECHO presentation called the Canadian Atlas of Palliative Care, Ontario Edition, Mapping the State of Access to Palliative Care Across the Province of Ontario. Again, thank you for your time. Before we get into the details of the Atlas, we'd like to start first on the next slide with a territorial acknowledgement. Next slide, please. Thank you, Elias. So just want to take a brief moment to acknowledge the land on which I am presenting from, which happens to be the city of Ottawa, which is the traditional unceded and unsurrendered territory of the Algonquin Anishinaabe people. The Algonquin people, as we know, have lived on this land since time immemorial, and I would like to take a moment to acknowledge the historical oppression of lands, of cultures, and the original peoples themselves in what we now know as Canada. And we all believe wholeheartedly that the work that we do collectively in palliative care can certainly contribute to the healing and decolonizing journey that we all share together. So very grateful to have the opportunity to be present in this territory. Next slide, please, Elias. So by way of introduction, I think it's always important to begin with a definition of what we mean by an atlas. And so I know some of you are very much aware of what atlases are, but really the overall aim of the Canadian Atlas of Palliative Care, for all the editions that we work on, all the provincial editions, it's really about raising awareness of the current state of palliative care in a given region, in a given province, in a given jurisdiction, ultimately to improve equitable and timely access to palliative care, to help identify and spread excellence, to help guide and inform policy making and planning and capacity building when it comes to the provision of palliative care, and to ultimately enhance the quality of palliative care in these different jurisdictions across the province. So really this atlas is going to, it does an, I think you'll find an excellent job at describing the current state of palliative care across a number of different domains and indicators, which I'm going to go through in just a moment. It helps identify and highlight areas of strength. So where are we doing really well? And what do some of these successes look like? And the purpose of that, of course, is to spread and scale these successes and where we're doing well to other regions or to other jurisdictions. It does also serve to identify opportunities to improve things. It does raise awareness of the status of palliative care for populations that we know require special attention. So children, 2S LGBTQI plus populations, incarcerated persons, recent immigrants, refugees, homeless, and marginally housed. And then also, it's an initiative that informs ongoing health system changes and improvements in palliative care, again, to ensure equitable and timely access for everyone who needs it. So that's a bit of an overview and a definition of what an atlas is. If we go on to the next slide, before we start to get into the nitty-gritty, I just want to take a moment to express really a big thanks to the core research team that you see here that I've had the pleasure and honor to work with on this edition of the Atlas. And again, this Atlas wouldn't exist without all of their work, their dedication, they're really a true commitment to advancing palliative care in Canada. Each one of these individuals has brought their expertise, whether that's from a clinical practice perspective, whether it's from a research or education or leadership perspective. And I think you'll see it's really reflected in the quality and the thoughtfulness of this work. So from the very beginning stages of design and methodology to the interviews that were conducted to the data analysis and the writing and the validation, really these individuals poured their blood, sweat, and tears into every step of the process. So on behalf of Pallium and everyone who will benefit from this resource, I really want to thank every one of these individuals for their tireless work in bringing this atlas to life. Next slide, please. And of course, we also wouldn't be here presenting if it wasn't for the funders who made this Ontario edition possible. And it's from their generous support that not only enabled the development of this resource, but also reinforced the importance of investing in data and evidence to strengthen palliative care across the province of Ontario. So big thank you to their contribution and their patience. The Atlas took a little bit longer than we had originally anticipated, but we now have a detailed and accessible snapshot of palliative care capacity and gaps and opportunities that are really unique to Ontario. Insights that will really help guide decision making and planning and hopefully future investments. So this project really is I think a true example of what we can achieve when funders, when health system leaders and community stakeholders all come together with this shared vision for compassionate, high quality palliative care. So again, on behalf of the entire team at Pallium and our partners right across the palliative care community, big thank you to these funders, in particular our lead funder, PSI Foundation. Really was their commitment to ensuring that all Ontarians receive the care that they need when they need it and where they need it. Next slide, please. An atlas does not come to life in a vacuum with one or two organizations. The reality is there is so much collaboration and engagement that takes place in the creation of these atlases. So we're very grateful to the many provincial and regional stakeholders across Ontario that you see here on your screen. They themselves contributed their leadership and their time and their insights to this project. Big shout out to OPCN, the Ontario Palliative Care Network. They were our lead provincial partner. They played such an important leadership role and really helped bridge connections with the other partners that you see here on the screen here. So again, the work would not have been possible without their collaboration. Again, whether this was through interviews or data sharing or strategic guidance, their input really helped ensure that the Atlas is both accurate, but also action-oriented. So again, their commitment to improving palliative care and the quality of care in their respective regions really, I think you're going to see is quite evident. And their leadership continues to set an example for others across the country as we continue to develop these other provincial versions. So big thank you to them. Next slide, please. Thank you. Really, the work for the Atlas began, believe it or not, prior to COVID. And it was really in response to the federal government's framework on palliative care in Canada, their strategic document that it called, among a number of things, for better ways to assess and monitor palliative care across the country. And it was this statement that we latched onto in that framework that was really the impetus for us to launch the development of the Canadian Atlas of Palliative Care. So we drew inspiration and guidance also from the international atlases that have been developed by the University of Navarra in Pamplona, Spain. So we had some great references and great amounts of work that the university over there had completed for atlases for Europe, for South America, for Africa. It was these atlases that really helped create a framework for us to create one for Canada. So when we got started, we brought together a research team that was made up of leaders in palliative care and primary care. So we're talking researchers, clinicians, educators from across different provinces and organizations, and even representation from the University of Navarra itself. And our work began with 2 pilot regions in Ontario, and it grew to include the development of 3 provincial atlases now. So we have one for BC, one for Ontario, of course, and soon to be relaunched, the Alberta Atlas. So our goal is ultimately to have 13 provincial and territorial editions, each with regional subsections, and also a federal level atlas that summarizes the status of palliative care at a country-wide level. And that'll, of course, allow us to compare how Canada fares against other countries. I think it's worth noting as well here that this edition of the Canadian Atlas of Palliative Care does not reflect palliative care services and programs of First Nations, Inuit, or Métis peoples. And really instead, and I say this with humility and in the spirit of reconciliation, Pallium Canada is really dedicated to collaborating in a distinct process led and developed by Indigenous peoples to describe palliative care across Turtle Island, Canada, provided by, with, and for Indigenous peoples. So a separate, distinct process. This is something we feel strongly needs to happen, and it was at their direction that we followed this. So just something to be mindful of as we're going through the data. Next slide, please. Okay, so let's get into this. We're going to start first with a description of the domains and the elements. So as you can see here on the slide, information in the atlas is presented across 9 domains. And within each domain, there are a number of elements. And these domains and elements are based on those that were used internationally from the atlases that I described earlier, but adapted for the Canadian context. They were then tested through a pilot study involving 2 of those Ontario regions that I just mentioned. That included, these regions were chosen specifically because they included urban and rural geographies and demographics. And the experiences and the learnings from those 2 pilot regions did inform additional modifications to the process and the domains and elements and the protocol that we used in the provincial atlas. The different domains and indicators really allow for comparison across the regions and to provide more detail given the large and varied geographies and demographics that is Ontario. So overall, the reporting of the results of indicators presented in the atlas falls into a few categories. Some indicators they're pretty straightforward to identify and measure. So for instance, if you look at a policy or a law, there either is one or there isn't one. So, or the presence of a palliative care unit or hospice residence, right? These are reported as either existing or not existing. Now, in some cases, they exist, but they exist partially. So, for instance, coverage of palliative care medications or supplies in a home setting. In these cases, we've reported them as being partial, so you'll see that word. Some indicators, though, are quite challenging to measure accurately right across this country. So, and province, the level of integration of palliative care across all hospital services and across all communities, frankly, just wasn't feasible given the resources that were available and the availability of the data and the significant variability that often exists, across communities and regions. And so for these, really a global judgment based on the multi-source input that we received was ultimately made. Next slide, please. Okay, so to obtain the best possible representation of the status across these different domains and indicators, and to reduce the risk of potential biases or inaccurate impressions of both informants and our researchers, this study purposely used a mixed methods, multi-source, and multi-informant approach. So we developed consensus through multiple stakeholder iterative reviews and that ensured input from different perspectives, multiple information sources, including health system leaders and frontline clinicians. So once the identification of the domains and indicators was finalized, we then obtained REB approval and established a collaborative partnership with OPCN. And then data collection began with the search for publicly available data, and that was done through searches on various websites and different reports. And at the same time, we began recruiting participants in collaboration with OPCN and the Ontario Health Regions. So standardized online surveys were completed by key informants from the province, from within the regions and from within the schools of nursing and medicine. And then we conducted interviews with other key informants to confirm or clarify or expand on the responses that we received in the survey. And then we held focus groups with individuals from within the regions and sectors to comment on the information that was collected publicly from the survey and from the interviewees, from the interviews. And then a final verification of the results was undertaken with provincial and regional leaders. I think it's really important, if I could just take a moment to clarify that Pallium's role in the development of this atlas, really our responsibility was to ask questions, of course, to gather data and report on what we heard, not to make recommendations or interpret findings through a particular lens or filter the information in any way. This atlas really is intended as a reflection of what was shared with us by the stakeholders right across the province. It really is their voices, it's their insights, and it's their experiences that really form the foundation of all of this work. Our goal throughout this has been to provide clear, evidence-informed snapshot of the current palliative care landscape. So we've approached this work really as facilitators and stewards of the information, really committed to ensuring that the data remains accurate, transparent, and grounded in what we heard directly from those working in and affected by the system. Next slide, please. Okay, so the provincial edition of the Atlas is divided into two parts. The first part reports at a provincial level, and then the second part at a regional level. And then the regional part is further divided into six subsections, each one representing or corresponding to one of the six health regions in Ontario. And the information within the Atlas is shared in a few different ways. So you'll see data that's presented on maps that will present different shades of blue based on levels of presence or availability of a service or a resource. And I think you see an example here on the right-hand side of the slide with respect to access to specialist palliative care. Uh, Data is also presented through dashboards where the extent to which a service or a resource is available is indicated through those colored dots that you see. And these circles can be accompanied by the letter V that indicates variability. And then finally, a megaphone icon will be shown when we want to highlight what we think is an innovative program or strategy. And the Atlas also has a comprehensive data dictionary that provides more information on the different terms, the definitions, and standards for the benchmarking of palliative care services that are used in this Atlas. Before I turn the floor over to Leonie to get into the data itself, I want to take a moment to explain one of the formats that we've used to present the Atlas data. It's something that we call a story map. And this is something that's developed using ArcGIS technology, which is an Esri candidate technology. So a story map is really, it's an interactive web-based tool that combines maps with narrative text and images and multimedia content, really to tell a story. It's a powerful way to present complex information in a way that's really easy to navigate and it's quite visually engaging. So for the Atlas, this format allows users to explore palliative care data and insights by region while also learning about the context and the stories behind the numbers. So it makes the data feel more alive and more relevant and more easily digestible, something that users can really interact with rather than just read in a static PDF document. We have that as well. So we do have a PDF report, but the story map really gives us a dynamic digital resource that we can continue to update and expand over time. And here you just see on this, this is the interactive story map itself. So you just a snapshot of what that looks like on the next page. Let's keep going. There we go. That's it right there. So, okay. So with that, I'm going to turn the floor over to Leonie, who's going to start with some high-level key findings and then start to tuck into some of the data. So Leonie, the floor is yours.
Thanks, Jeff. We can go to the next slide, please, Elias. Great. So just as Jeff said, some high-level kind of overview of what our key findings are for this Ontario edition of the Atlas is really to really congratulate and appreciate actually the work that's been done at a provincial level to both establish legislation and provincial frameworks to really guide palliative care, and that Ontario has a very, robust foundation in frameworks to lead the quality and standards around palliative care. So that's a big kudos to OPCN in particular. One thing that was very challenging in the work we did to collect data, especially around palliative care beds in the province, was that there wasn't a good standard and definition around what a palliative care bed is. And so it led to difficulty in collecting data across the regions, and some regions had actually different understandings of what a palliative care bed was than another. So it was difficult to get the information, but also the regions indicated to us that it was actually an impediment to them to be able to do robust palliative care planning for the resources that is needed, and has caused some challenges there. Um, Overall, there's a significant lack of acute palliative care beds. So as we'll go into the data, while there are, adequate kind of beds within the hospital settings, most of them are being used for end of life care and functioning in that capacity. Um, Primary level palliative care is largely being delivered by specialist teams in many of the subregions, and we'll dig into that a little bit more. And equitable access to palliative care remains a significant challenge for a number of underserved populations, including pediatric patients. And one thing that's quite remarkable in Ontario is there's a very strong community of palliative care researchers and academics out of many of the university centers that are leading quality improvement and active research programs and improving even education in palliative care. So a big shout out to that. So we'll move on to the next slide, please. So, as Jeff described, the atlas was built onto some really remarkable work done at the international level, led by the University of Navarra. And the other country atlases have not had to dig down to another level that we did in the Canadian atlas, because of the way that healthcare is organized at a provincial level. And then, even within the provinces, many of the regions do things differently. And so we added another layer of information and data collection from the international atlases. And so we've collected information both at the provincial level through all of the methodology that Jeff described, as well as at a regional level. So when you go into the PDF or the story map, you'll see this, both, as Jeff has said, the 6 regions plus the provincial level data. We were able to get down to some additional detail once you got to the regional level, and we'll give you a snapshot of that today as well, to see really you can dig into some of the more details about where hospices are, where are the palliative care beds, examples of what's being done really well that we can all learn from in some of the smaller communities even. And so encourage you to, think about what you want to really focus your time on, whether you're wanting to look at a particular region or a particular service across regions. There's a lot of ways to really look at the data. But first, I'm going to give you an overview of those key domains and many of the elements and indicators that Jeff gave you a summary of at the provincial level. And we don't have time today, of course, to go through all 6 regions. So we'll just, as I said, give you an example of some of the additional detail available at the regional level. Next slide, please. So from a demographic perspective, there's more detail in the atlas, but we really capture using the 2021 census data. So that's important to keep in mind when we're talking later about population projections and beds that are needed. We look at population density, population size, age range, as well as cause and number of deaths. So this here you can just see really highlights how vastly different the 6 regions are in Ontario, from very rural regions like the Northeast and Northwest, where you have less than 1 person per kilometer squared in terms of population density, and then to Toronto, of course, which is 4,000 times that density. So always important when you're looking at the data to keep in mind the unique geographic and population needs of a region, and indeed the province. So always center ourselves in that respect. Next slide, please. When we look at policy, this domain includes a number of elements. And as I gave you in the summary, the really something Ontario has done very well is that there is a provincial law to ensure palliative care access, the Compassionate Care Act, and a number of very robust frameworks that have led, like the community model of palliative care, for example, by OPCN, that have really given strong foundations for improving palliative care, and the hospital model of care, which has just been released. And not we weren't able to speak to this in the atlas because it's not out yet, but we know that there's a pediatric framework as well under development and coming. So there are, lots of really good standards that can guide palliative care. And within Ontario Health, they've also put forward leads in each of the 6 regions, as well as implementation leads to help move that work forward. So very significant investment in moving palliative care forward through that work. In terms of strategies, there's strategies through, as I mentioned, the community model of care for home and community care, and the hospital model of care, so inpatient and outpatient hospital services. And long-term care facilities have a strategy through the Fixing Long-Term Care Act in 2021. While there's no specific strategy for rural and remote, there's some coverage of that, of course, through the community model of care, but that might be an opportunity to consider how to strengthen that. Paramedic and emergency services are listed as formal because the organization of emergency health service is done at a county level in Ontario. And so there are some very significant initiatives being undertaken in some of the counties where they have actually paramedic palliative care programs, and in other counties and regions, there's not a lot of activity happening. So that's why you'll see that it's registered as partial, and there's no uh, province wide strategy to address that at this time. From a funding perspective, like many places in Canada, funding inside the hospital for palliative care services, whether it be medications and supplies, is full. And once you move out into the community, there's more of a reliance on charity and donations with respect to hospice services, and home care has partial funding in the sense of um, there's restrictions in some regions on prognosis. So you might have to be in your last 3 months of life or your last 12 months of life. There may be home care services available daytime, but not after hours in particular areas. And so that's why you'll see partial presence there at this broad provincial level. And then, of course, supplies outside of the hospital and medications, they are covered by the provincial palliative care plan, and again are partial because they're prognosis specific. Next slide, please. So this slide, I'm going to spend a few minutes kind of breaking down because there's a lot of information. It can be very confusing, in part because there are no clear definitions for palliative care beds in the province. And so we've done our best to pull together what we could using our standards of the elements that are used internationally and that we're using across Canada, and try to really apply them and understand them in Ontario. So I'll start by saying that it was very difficult, as I've already said, but it bears reiterating, to collect really accurate data because of that lack of standardized definition across the regions. But in the atlas, we report on two types of inpatient palliative care beds. One is hospice beds, and the second is palliative care unit beds. Hospice beds can be located in freestanding hospice residences, or can also be in continuing care facilities and in Ontario regions in community hospitals. So these latter two, the beds in continuing care facilities and community hospitals, are denoted here on in the atlas as other hospice beds. And palliative care unit beds can be located in units that are solely dedicated to palliative care, or can be beds that are co-located in a mixed unit, such as shared with medicine or oncology. And so those mixed units where there are beds for palliative care that are dedicated to palliative care in those units are denoted as other palliative care beds. It's important to note that we only counted beds that were dedicated and specifically funded for the purposes of palliative care in the determination of adequacy, and I'll explain what we mean by adequacy in a moment. But some hospitals across the province have designated or floating beds that can be used by palliative care if they're available, but they are not guaranteed to be available if a patient needs it for palliative care, because they're usually medicine beds or hospitalist beds or other types of units. And so they may only be periodically available depending on the operations and the other care that's required there. And the staff that provide that care are not dedicated to palliative care. So when we're looking at recommendations around what a population needs for types and numbers of beds, we are specifically looking at ones that are dedicated with staff that are trained in palliative care, and those beds are available when folks need it. So that's an important thing to note, because there are a lot of designated beds in Ontario. So when we talk about adequacy, that refers to the minimum number of recommended beds per 100,000 population as determined by a conservative tool that's recognized internationally as a reference standard called the Catalonia formula. The Catalonia formula, which, as I say, is a very conservative measure, recommends 10 beds per 100,000 population. Three of those beds should be acute palliative care beds, focus on symptom management and early supports, integration of palliative care supports, symptom crisis, and have a live discharge rate of at least 30%. Um, and 7 of the 10 beds should be used for the purposes of hospice and end of life care and continuing care type beds. So that's what we look at when we're saying adequacy here. So if we just have a look at what the data we collected here provincially, there are 35 dedicated palliative care units across Ontario, from what we could determine, and 579 beds within those units, which is overall adequate for the number of palliative care unit beds that are needed when you're thinking of the 3 per 100,000, but recognizing that actually in Ontario we found most of those beds are being used for end of life care rather than that acute palliative care unit. And there are, when we dig into the regions, you will see there are some very good examples, like Princess Margaret in Toronto, for example, and the Ottawa Hospital, of units that are truly providing acute palliative care, but by and large, that's not how the units are functioning. When we look at hospice residences, there are 64 hospice residences with a total of 578 beds, which is about 53% of what's needed based on that 7 per 10 out of 10 for 100,000. And when you look at all the inpatient beds combined together, so that minimum of 10 per 100,000, we have lack of beds to meet the population needs based on the 2021 population. Of course, the population has changed now by 2025, and we may be more underestimating the number of beds that are needed. So important to, of course, take this into context with current population. Next slide, please. When we look at access to specialist palliative care teams in hospitals, overall across Ontario, and you can see the color coding on the map on the right, but overall there's a partial high access to specialist palliative care teams in the hospital, and most of the larger urban centers have in-person teams who are on the ground seeing patients. Many of the more rural and remote areas, of course, rely on virtual support. And so that impacts, of course, so you can see in the Northwest and Northeast the availability of the teams. And for an example, in the Northwest, there's a consult team in Thunder Bay that provides on the ground consultation in the Thunder Bay area, but of course can't physically get out to the rest of Northwestern Ontario. And so they that on-call group does provide 24/7 call availability, but that's rated, when you dig into the data, as partial low because it's not available in person, and there's nobody kind of on the ground that can come in and help. Um, so funding models for physicians across the regions to provide specialist palliative care team, we look at that because that has impact potentially on the model of care that's being provided. So whether it's a fee for service versus a clinical ARP can impact the type of care provided. And overall across the regions, there's quite a mixed variability of funding models. And you'll see more details of this at the regional level. But overall, not surprising, I think, that there's a heavier reliance in the more rural areas on remote and virtual support. Next slide, please. So when we look at integration of a palliative care approach within other inpatient units, so now of course we're talking about medicine, oncology, surgical units in hospitals, not dedicated palliative care units. We're really looking at whether the teams themselves are providing a palliative approach to care for those patients, and using our mixed methodology, it's an overall understanding of what's happening at a regional level, because of course there are great examples of excellence in individual hospitals and teams, but we're looking very broadly at what's happening across the province or region. So in this case, province, and the integration of a palliative approach within an inpatient units, and liaising with specialist palliative care and involving them when things are more complex and they need that help, is overall being done well at a partial high level. But once you look at integration within the outpatient setting, there's less integration by the teams themselves, and there's a higher reliance on specialist palliative care teams providing the support themselves, and that is the palliative care that's available. For example, in the cancer center, the palliative care is not being provided, the palliative approach is not being provided by some of the oncologist, but is relying on a referral to a specialist who sees them in their own specialized clinic. So there are, examples of some integration happening, especially within specific tumor groups, that was noted in many of the regions. But overall, it's a partial low that's happening across the province within cancer and non-cancer. There were some really good examples of excellence of integration of a palliative of approach happening in renal care in particular, and wanted to, you'll see through the atlas's highlights, as Jeff mentioned, and here we really speak to the work that the Ontario Renal Network has done to develop integrating palliative care approach within chronic kidney disease care, including developing identifying and supporting local champions to develop palliative care within each of the 26 renal programs, including training in LEAP Renal, for example, and looking at person-centered decision-making, serious illness conversation training, for example. And I know there's some examples too that we've captured in some of the regions around really good integration that's happening in some clinics, like in the heart clinics in Ottawa. So things that can be scaled and spread, but overall opportunity for improvement is integration within cancer and non-cancer settings, and especially in outpatient. Next slide, please. So the next domain is looking at services within the community. And we're looking at access to specialist palliative care teams, as well as the access after hours specifically. And both of those are actually being done fairly well to a partial high level across most of the regions, of course, with variability and hence the V there. In particular, there was less availability of specialist teams across the rural regions. So Northwest and Northeast in particular had less availability. There's a consult team available in the Sudbury area, but outside of the Sudbury area, no specialist palliative care team except for virtual support. Next slide, please. Palliative home care was fairly challenging to determine because during the time we were collecting the data for the Atlas, Ontario Health at Home was being formed, and we were not able to get permission from them to engage with them directly. And so we had to be quite sleuthers and gather all our information from all of the regions as much as possible. And of course, there's variability across regions with respect to both the level of support that can be provided. Some places it was daytime only, some places it was 24/7, as well as the continuity of nursing staff available due to difficulties with staff retention and turnover, in particular in the more rural regions. In some rural regions, palliative home care is actually provided by general home care, for example, in the Northeast region. And so those staff are not specialized in palliative home care, but have taken on the role of providing palliative home care. So overall, there's more availability of daytime supports for palliative home care, and it was felt to be largely available, so partial high, by all of the stakeholders we engage with. And there was less availability of 24/7 access, again, due to these constraints with staffing, and in particular in the more rural regions. So you can see in the west here, there is more full access, central and east, more partial high, and then partial low in those rural regions. Next slide, please. When we look at the community domain, we look both at primary care and then a bit more specifically at rural and remote regions, which we know are underserved with respect to palliative care. The overall provision of primary palliative care by family doctors and nurse practitioners providing that palliative approach to their own patients is overall partial low. And I think we all know the significant challenges that primary care are facing across the country, but in Ontario, such to the point that has been prioritized by the Ontario government. And hopefully they will be looking at palliative care as part of that work that Dr. Philpott is leading. There's a higher level of palliative care approach being provided to patients that are seen within a clinic setting by family doctors and nurse practitioners. But once you get outside of the clinic setting and patients need home visits and after hours care, very little, minimal to absent is by and large being provided across the province. And certainly at the regional level, we do give some examples of excellence that are occurring, for example, in Guelph and in some areas of Ottawa, and in Hamilton, just to name a few. And there's more of that primary palliative care available actually in the rural and remote regions where family doctors are more often take on the palliative care needs of their patients, but overall, significant gap, especially in after hours and home visits. As we've discussed, there are indicators for primary palliative care through the community model of care that OPCN has, and there's training available, but not necessarily always funded training, which is why the partial designation is given there. With respect to the rural and remote regions, um, there's partial low access um, to specialist palliative care services and no specific strategic plan to look at the unique needs of rural and remote, although rural areas would be covered, as I said, in that community model of care. And there is funding available and some training that's been happening on a palliative approach to care specifically for clinicians in those areas. Next slide, please. With respect to long-term care, there's overall partial low access to specialist palliative care services. Of course, there's very significant variability across regions and even within long-term care homes within a specific region because many of them are privately owned. So difficult to get data. You'll note here on the map on the bottom that the West region felt that they weren't able to give us the information because it wasn't something known to them, and there was such variability. So we first did our best to put together the data that we had. It's I think important to highlight that the Northwest region's actually been doing a very significant number of quality improvement initiatives and have developed a community of practice that's run out of the center in Thunder Bay. And so they have done a really remarkable job of integrating a palliative approach into long-term care, and definitely a region that others can look to for scale and spread about how to improve palliative care within long-term care. And there are, as we said, standards around the Fixing Long-Term Care Act about palliative approach that's expected within long-term care. So things that can be leveraged by folks who are looking to improve and prioritize this area of palliative care. Next slide, please. With respect to hospice services, Hospice Palliative Care Ontario has standards and indicators for hospices, but it's up to the individual hospice whether they want to uptake those standards, and so that's why there's a partial designation. So not all hospices adhere to those standards and monitor them. Um, again, some discrepancy in the numbers of hospice residences that we were able to find public-facing data versus what was reported to us, but overall. We There's about 661 hospice residences. That includes pediatric and adult-based hospices, and at least 85 community hospice organizations that we know. One thing I think that is really clear to us in the work that we did, like many places in Canada, is that both the community hospice organizations and hospice residents largely rely on funding and donations to run their services, and which obviously can be very challenging, but are doing very incredible work to help people live well in their communities. And we'll speak a bit more about this when we go into some of the volunteer and caregiver programs that are largely run out of those organizations. With respect to training paramedics in palliative care, as we indicated it kind of in that first slide on policies, it's up to the county level who are responsible for emergency health services. And so some counties are providing palliative paramedic programs and others aren't. So that's why you'll see partial and variable. There's no provincial strategy. Next slide, please. With respect to palliative care resources, there's many provincial organizations providing resources, and one that's commonly used is Speak Up Ontario. And with respect to palliative care competencies for different professionals, the OBCN has developed a comprehensive document that looks and outlines that for palliative care approach as well as specialist palliative care. Next slide, please. System performance in the Atlas, look we don't gather data on system performance, but we report on what is being done. And so Ontario Palliative Care Network and Ontario Health and Health Quality Ontario have provincial level system performance indicators that are collected and reported on regularly. And so those can be accessed through their websites and with requests for information for them. Next slide, please. Education, so this is the broad strokes provincial level education, and then we have additional details on each of the universities and schools and what they're doing at the regional level. So just broadly, the Atlas looks at medical and nursing schools. We don't have the resources to look beyond at other professions. It was very difficult as it was to get information on nursing schools in particular, but we were able to get fairly robust information on the medical schools and the training programs, and you can see the number and types of schools here. We do note that the TMU has a new medical school as well, and that programs that are coming there. And there's additional information in each of these domains where we give specific examples and further details, but there are both programs for adult and pediatric subspecialty palliative medicine training, as well as the 1 year added competence for family physicians to get more training in palliative care across the province. And the nursing specialization for CHPCN certification, of course, is a national certification, and so that's not school specific. Next slide, please. I should just say that there's further details on you know, what's integrated within undergraduate curriculum when we were able to get it in the nursing schools at a regional level, as well as the medical schools we were able to get that information from, and what rotating residents are getting for training in palliative care. So that's all in the regional level. One of the second last domains is professional activities. So, of course, there's palliative care organizations, including HPCO, OPCN. There's directory of services available. Each Ontario Health Region has resources dedicated to continue professional development of palliative care, as well as many of the universities. There's lots of palliative care education symposia happening. Um, lots of robust academic work, as we said, through research at many of the universities, and quality improvement initiatives happening across the regions outside of universities and hospices, long-term cares, and other clinical programs. Next slide, please. So focus populations, and I'm going to wrap up in the next 5 minutes to make sure we leave about a good 10 minutes for questions. There's no formal strategy currently existing when this atlas was collected as of the end of December 2024. But of course, we understand there's one coming soon. There are pediatric hospice residences in Ontario, and again, more details given at that regional level. There are outpatient programs as well as respite services available, and consult teams based out of most of the tertiary pediatric hospital centers, and 24/7 access to specialist palliative care team. Overall, when you look across the province, is partial because many of the bigger rural regions rely on virtual support only. So, for example, the whole region of the Northeast, if they need specialist consultation for palliative care, pediatric palliative care, they are calling London Health Sciences. So just to give you a sense of, while there are consult teams, at the children's hospitals in most places, a lot of that care outside of those centers is virtually provided. And of course, there are education programs happening across the province, and many of those pediatric centers like Toronto, Hamilton, London, and Ottawa are running education programs, as well as LEAP Pediatrics is being used across the province as well. Next slide, please. When we look at other focus populations, you can see the different populations that we examine, and there are no formal strategies or programs at a provincial level. When you go down to the regional level, we give and describe examples of really excellent work being done. And I think many of us have heard of the Peach program, for example, in Ottawa, the Journey Home Hospice, just to name a couple that are supporting homeless and marginally housed people. There's work being done out of Hamilton for immigrants and refugees, and in Ottawa area for the Francophone population, Maison de l'Est. How do you say it, Jeff? You can connect. Obviously, I'm not Francophone.
Perfect,
Yeah.
spot on. Maison de l'Est.
Yes, is serving providing hospice services for Francophones. So there is examples of work that can be again scaled and spread, but nothing formally happening at a provincial level. Next slide, please. Community engagement, lots happening in terms of programs and initiatives for volunteers and training programs. Many of those are run out of the community hospice organizations and the hospice residences. And there's the Caregiver Ontario, I've forgotten the full name, which I feel very embarrassed about. But Caregiver, what's it called? Um, Anyway, I will Ontario Caregiver Association. Got it. Okay, which is a really great resource for supporting caregivers and education and resources. And grief and bereavement services are largely being provided by the community hospice programs and hospice residences, which again rely on those charitable donations. So quite a lot of community engagement happening, and I think we know there's many compassionate communities initiatives across the province as well that are growing. Next slide, please. So in my last 2 minutes, I'm just going to give you an example of some additional information that you can drill down in when you're interested in doing so at the regional level in particular. If you can go to the next slide, Elias. Um, we give a lot more information at the level of palliative care units and hospices, where you can go into the story map and scroll over. This is an example of the Ontario East region. So what you can see is like not only the number of beds and the number of units, but also exactly where on the map these units are located, the type of hospital setting they're in, whether it's a continuing care facility, community hospital, acute care, whether they're primarily providing end of life versus mixed, which would include symptom management and end of life, the numbers of beds, and whether it's, when we get to the hospices, we'll also, next slide, please, denote whether it's pediatric hospice versus an adult hospice. And remember that these beds are the ones that are dedicated for palliative care. So we're not mapping the designated floating beds that are not guaranteed for palliative care. And this was again as of December 2024. So this does not capture hospice beds that have the government has announced but have not yet been put into place by December 2024, and any changes, of course, since the end of December. Next slide, please. I think that's it. Back to you, Jeff, for wrapping up here.
All right, very good. And there was a comment, and thank you for correcting us. The Peach program is indeed a Toronto-based program, not Ottawa. So thank you for that.
Yes, sorry,
Uh,
that was a slip of my tongue. I meant to say
that
that.
is,
I
yeah,
was,
no,
yeah.
uh, no worries, and thank you, anonymous attendee, for correcting that. Okay, great. Well, listen, we do have a few moments for questions, so do want to open it up. You can either, well, what we encourage you to do is put your question in the chat. And you can see that, of course, at the bottom of your screen. I'd like to open it up to anyone that may have any questions on the atlas or any of the data that Leonie has just walked us through. And I believe I think it's the Ontario Caregiver Organization. Good. Any questions? Okay, one here. Who owns the atlas and how often will it be updated? I was just gonna, if someone didn't ask this, I was gonna mention this anyway. So um, let me start by saying the Atlas took us almost 2 years to complete. And it's, as you can imagine, just if you reflect back on the methodology, the amount of time it takes to collect the data and connect with very, very busy healthcare professionals, it can take quite a bit of time. So we're following the best practice from our colleagues at the University of Navarra and Pamplona, Spain, who update the atlases that they've been working on over the past 10 plus years every 5 years. Okay. Who owns the atlas? Well, everyone owns this atlas as far as we're concerned. We at Pallium Canada, along with our partners at McMaster and our funders, work together to collect this, but we see this as everyone's tool. We just are the stewards of what has been the data collection and the capture of this information, but really we don't see it as ownership as much as we are stewards of the information that we have. Okay. How does the atlas track the aging within regions and the impact of that? Do you want to take that, Leonie?
Unmute first. Yeah. So we don't we track a snapshot in time. I guess that's what we capture is the proper word, a snapshot in time. So we can only use the census data for population data, and so I actually highly encourage you at a regional level in particular to look at the current needs of your population and how that might impact and how it might compare to what we captured from the 2021 census data. Because of course, uh, a region that has higher aging population with more multimorbidity and a higher death rate will have different palliative care needs. than a population that has, say, a lot of younger people and immigrants and refugees that have different types of complex needs. So I think we would encourage you to really understand your unique population needs and then look at the atlas data through that lens. That would be the best way, I think, to go forward. So we cannot track in real time changes in populations with a static mapping process.
The other question that we have here is around, will there be socio-demographic data aspect to this atlas? People see the data on the gender and the age, but beyond that,
Unfortunately, we don't have a
no,
way to collect that information.
no, that's right. There isn't a mobile app version, but I will say that the story map, which you can access from any smart device, is much like an app. It's very friendly to be leveraged on an iPad or on a device. So no plans to bring a mobile app version, but certainly the story map um, acts much like one. So just are there any plans, more specifically racial groups?
Yes,
Uh,
so we don't have that
no.
information because we can get that information at the regional level, and it's not consistently available across the country. So kept to the very specific um, indicators that are used in the other international atlases in terms of population density, age distribution, and types of
Mhm.
death rates and what people died from. But of course, you can look at that for your own regions again and apply the atlas information through that lens.
And Robert, thank you for that question. I did answer that. Drop me a note at the email address I shared with you. Thank you. Well, I know we're coming close to the top of the hour here. First off, a big thanks to Dr. Leonie Herx for, well, of course, not only for her leadership on this atlas, but for her time today presenting the overview and the highlights of the Ontario Atlas work. I believe my friend Elias has also put a survey in the chat. So listen, the only way we're going to make these sessions better and more productive and beneficial for everyone is to hear from you, to get your feedback. I hope today gave you a really good overview of what the Atlas is all about. The Atlas, it really is about leveraging the data contained in there to either become better informed, to build your cases for support, or to point out areas of success or where we need to shore things up. So really, we want to see this thing being used and we want to hear how you're using it. So please do share that information with us. But in the meantime, complete that survey. Let us know how we're doing. And keep your eyes peeled for future editions of the Atlas for different provinces and territories, and hopefully the national one, and of course the First Nations, Inuit, Métis versions as well. Thank you very much for your time. If there are no other questions, I see that Elias has put up the final slide, which is, again, how to leverage the Atlas. You can scan that QR code if you want there. And big thank you to all of you for taking time out of your schedules to learn more about the Atlas. I wish you a great rest of your day. Thanks, everyone. Take care.